everyone, my name is Robin Tumlinson and I'm a fourth year pharmacy student at Auburn University. And today I'll be doing a brief overview of necrotizing enterocolitis, primarily from chapter 13 of the NICU primer for pharmacists. So necrotizing enterocolitis, or NEC, is a gastrointestinal infectious disease. It is characterized by ischemia within any part of the intestine, but usually involves the terminal ileum. The cause is not entirely known, but it is related to an interplay of intestinal flora, intestinal perfusion, enteral nutrition, and stress. It is most common in preterm neonates with low birth weight, with about 90% of cases occurring in premature infants. The median onset is 10 days after birth, but this is inversely related to gestational age. So the more premature the infant is, the later you may see the onset, and vice versa. The overall mortality ranges from 10 to 50%, so this is pretty serious if it does develop. This figure helps to show the interplay of factors that can contribute to NEC that we just talked about, as well as a few more, such as immune defense and genetic predisposition. So the presentation of NEC, it's divided into staging criteria called Bell stages based on the severity of the presentation. Bell stage 1, or suspected NEC, may present with symptoms like a history of stress, GI signs such as abdominal distension, bloody stools, or poor toleration of feedings. You may also have systemic indicators like apnea, bradycardia, and temperature instability. And you may also have abdominal distension with mild ileus on radiography. Bell stage 2, or definite NEC, would have similar features to what we just said in stage 1, but you would also have things like gross or persistent GI bleeding and significant abdominal distension with ileus, small bowel edema, pneumatosis intestinalis, or unchanging rigid or fixed loops of the bowel. Bell stage 3, or advanced NEC, would have the same symptoms as stage 1 and 2, as well as more systemic symptoms like worsening vital signs, septic shock, GI bleeding, or pneumoperitoneum, which is having gas in the peritoneal space. This is just a table of the modified Bell staging, which includes subcategories for each of the 3 stages and treatment approaches for each one. So I won't go over all of this, it's just here for reference, but just some additional signs to point out are leukopenia, leukocytosis, thrombocytopenia, or metabolic acidosis. This table just shows sort of what this may look like. So you can see the part of the small intestine that has NEC, it's very inflamed. And it also shows a cross section of an intestine with NEC compared to a normal healthy intestine. So for diagnosis of NEC, it's pretty similar to those symptoms we mentioned before, like abdominal distension and tenderness, bloody stool, intolerance to feedings, abdominal radiographic findings. And if you have pneumatosis intestinalis, that does confirm the diagnosis. And that's when you have presence of gas in the wall of the small or large intestine. For treatment of NEC, you want to stop enteral intake. You may restart parenteral nutrition or fluids. You want to initiate bowel rest and GI decompression, which is the removal of contents of the intestine by suctioning. And then you also want to perform an infectious workup. In advanced NEC with systemic symptoms, you may also have to provide supportive care with fluids, inotropic meds, blood products, and possibly respiratory support. You also want to start empiric antibiotics, and so this should be IV treatment. You want to cover for gram-negative and gram-positive bugs and possibly for anaerobes, and this treatment can be de-escalated based on cultures and sensitivities. So for gram-negative and gram-positive coverage, you could use something like ampicillin and gentamicin, or vancomycin and cefotaxime. And for anaerobic coverage, you could use something like metronidazole or clindamycin. Anaerobic coverage may not add benefit. However, it should be considered if you suspect or know that there has been a perf, if there's pneumoperitoneum, or following surgery. Surgery is typically in advanced cases of neck. It should be done in conjunction with medical treatment, and it's warranted if a pneumoperitoneum is present, which is a surgical emergency, if you have worsening clinical or laboratory signs, or if you're just not improving with medical treatment. And there are two different surgical approaches. You can do a laparotomy where portions of the necrotic intestine are removed, or peritoneal drainage, which removes inflammation and infected fluid from the peritoneum. This picture helps to see what that surgery might look like. So you can see the diseased part of the bowel is removed and an ostomy is created, and then later on the cut ends of the bowel would be rejoined. And for duration of antibiotic therapy, if you have just suspected neck, you may only treat with antibiotics for 72 hours. For definitive neck, you may treat for 7 to 10 days or up to 14 days, depending on the situation. And if you have severe neck requiring surgery, you would treat with antibiotics for up to 21 days following the surgery. There are some risk factors that can increase the risk of developing neck. Some of these would be medications. So extremely low birth weight infants with sterile cultures who receive more than 5 days of empiric antibiotics started in the first 72 hours of life may have an increased risk of neck. Or indomethacin use as a tocolytic in preterm labor has been shown to be associated with increased neck. Red blood cell transfusions may also be a risk factor. Very low birth weight neonates may have an increased risk of developing Bell stage 2 or 3 neck within 48 hours of a packed red blood cell transfusion, but the studies on this are sort of conflicting. And then congenital heart disease may also be an increased risk factor, such as ductal dependent congenital heart lesions. The use of prostaglandin infusion for single ventricle cardiac defects may increase risk, and hypoplastic left heart syndrome. So prevention of neck is very important because it's obviously a pretty severe disease. Some things you can do to prevent neck is the use of human milk, which may have protective effects. Neck risk may be reduced proportionally to the percent of human milk as the total enteral intake in the first 14 days of life. Trophic feedings, which are feeds less than or equal to 20 mils per kg per day, can help to induce GI enzymes and stimulate peristalsis. Neonates receiving up to 10 days of trophic feeds have a decreased risk of neck compared to those who advance feeds quicker. Probiotics may also prevent Bell stage 2 and 3 neck based on a systematic review. And then antenatal corticosteroids, which we know help to promote lung maturation, can also help to promote GI tract maturation, which can decrease the risk of neck. So in conclusion, neck is caused by an interplay of multiple components that may be different in different infants. It can be a very serious disease with serious outcomes and can cause late complications too, such as abscess, fistulas, and malabsorption. So it's important to treat appropriately with antibiotics and surgery if that's indicated. And like we said before, the best thing you can do is minimize the risks of developing neck in the first place. And that's all I have today. Thank you for listening.